Good morning, everyone. Myself, Dr. Sanjeev Tomar. I am an associate professor in the Department of Oral and Maxillofacial Surgery, Santosh Dental College in Ghaziabad, Delhi NCR, Santosh deemed to be university. Today, I will discuss about the dissection osteogenesis. What is dissection osteogenesis? Dissection osteogenesis or bone lengthening is a surgical procedure which involves cutting and slowly separating bone, allowing the bone healing process to fill in the gap. It is an established surgical technique that allows for molding, shaping and lengthening of the bone. This process involves making controlled cuts and osteotomies in the bone and using a device to gradually separate or dissect the bone fragments. The fragments are then held apart by the dissection device over a period of 1 to 3 months, during which new bone forms, a process called osteogenesis. Dissection osteogenesis has been used in orthopedic and hand surgery to lengthen bone in the extremities, and the technique has more recently been applied to the craniofacial skeleton. Now we will discuss about the history and evolution of the dissection osteogenesis, how it started. Dissection osteogenesis has been performed for over 100 years. It was first performed by Alessandro Cordovilla in 1905 to lengthen femurs in a series of patients with well-formed legs. In 1950s, a Russian orthopedic surgeon named Gavril Ilizarov studied and improved the technique, applying it to the long bones of the lower extremities. His research helped elucidate how dissection osteogenesis works on a cellular and physiological basis and the ideal tension, rate and rhythm of the dissection. After that, Joseph McCarthy pioneered the use of dissection osteogenesis in the craniofacial skeleton in the early 1990s. In craniomaxillofacial region, the first clinical application of the dissection osteogenesis was reported by McCarthy in 1992 for mandibular lengthening. The success of mandibular lengthening has paved ways for many other craniomaxillofacial regions involving other regions such as the alveolar ridge, maxilla, midface as well as in the cranial vault expansion also. Now I will discuss about the indications where we can apply this technique. Regardless of the anatomic site, the goal of dissection osteogenesis is to elongate the fusion bone in order to restore more normal anatomical function like mandibular hypoplasia, Pierre-Robin sequence. Neonates may present with airway obstruction secondary to mandibular hypoplasia. Pierre-Robin sequence (PRS) describes a triad of micrognathia in conjunction with glossoptosis and cleft palate. These patients will often have a feeding difficulty in addition to intermittent upper airway obstruction due to the retro displacement of the tongue. When conservative measures have failed, like prone positioning, nasopharyngeal airway, tongue lip adhesions, etc., mandibular dissection osteogenesis has provided a viable alternative to tracheostomy placement. Dissection can also be used in a vertical vector to increase the height of the mandibular ramus as a component of craniofacial microsomia. We can also use the dissection osteogenesis procedure in the midface hypoplasia also. Midface hypoplasia can present as a result of severe craniofacial syndromes like Treacher-Collins syndrome, Cohen syndrome, etc., and in patients with isolated cleft lip or cleft palate. Patient will often have visible malar retrusions, class 3 malar lesions, and a degree of astigmatism due to isolated retro displacement of the inferior orbital rim. Similar to mandibular hypoplasia, patients may present with airway obstruction or severe sleep apnea. Dissection osteogenesis has proven a useful tool in correcting these deformities. Craniosynostosis. What is this? Craniosynostosis describes the premature fusion of the calvareal suture lines. If left untreated, the condition can result in severe craniofacial deformities, intracranial hypertension, cognitive impairment, developmental delay, seizures, blindness, and it can cause the death also. Dissection osteogenesis provides an alternative to traditional surgery for single or multi-suture craniosynostosis. This can be used to expand the anterior or more commonly the posterior cranial vault. Increasing the size of the cranial vault provides relief to the increased intracranial pressure caused by craniosynostosis. Contraindication for the DO. Patients who are not surgically candidates due to concurrent medical problems should avoid craniofacial distension osteogenesis. If conservative measures are well tolerated and alleviate the afflicting condition, then they should be used in preference to surgical management, especially in young children. Positional plagiocephaly must be differentiated from true craniosynostosis, as the former is managed exclusively non-surgically. Now we will discuss about the principles of distension osteogenesis. What are the basic principles? In a normal fracture healing, soft callus formation, callotrosis, allows the fracture site to heal. With this principle, distension osteogenesis involves the manipulation of this callus in the distension chamber for structural lamining before calcification occurs. Corticotomy is a process where osteotomy to the cortical layer of the bone is performed in order to separate the segments, while at the same time preserving the blood supply to the bone from the medulla and periosteum. So we follow some principles in this manner. We follow the distension rate and distension rhythm. What is distension rate? Distension rate in distension osteogenesis describes the distance in millimeter in which the bone is moved per day. And distension rhythm describes the frequency of device via device activation per day. How many rotation we give to the device, that is the distension rhythm, and how much millimeter we move the bone, that is the distension rate. Distension osteogenesis comprises of three sequential phases: latency phase, distension phase, consolidation phase, which is distinct in every aspect. These phases are simplified in the illustrations. What is latency phase? A time period which is required for the formation of callus. Elizarov suggested 5 to 7 days, but this depends on the microvasculature and physiological state of bone formation over the distension site. At cellular level, there is hypoxia occurring over the osteotomized structure, inducing angiogenesis, response and migration of mesenchymal cells to help produce collagen synthesis. Latency period should be short enough to prevent calcification and long enough for adequate callus formation. After the latency phase is over, then comes the distension phase. To achieve target bone growth, the rigid distension device needs to be activated as per suggested protocol. The device is activated by turning axial screw with a movement of 0.25 to 0.5 mm. Depends upon the system we are using. So we have to activate the device 0.25 to 0.5 mm per turn. And the success of distension depends on the rate and the rhythm of the distension. If the distension is carried out fast, by increasing the rate and frequency, it may lead to ischemia at the cellular level, causing malunion over the distension site. In contrary, reduced rate and rhythm may lead to early ossification, thus indirectly causing complication to the distension. Clinicians worldwide tend to keep the frequency of 2 to 4 times of activation per day with the target of 1 to 1.5 mm distension per day. Histologically, 10 to 14 days post-distension, osteoid synthesis starts at the margin of the osteotomized bone adjacent to the blood vessels. At around 3 weeks post-distension, progressive calcification starts to form bone spicules. When the distension phase is over and we have achieved the desired length, next comes the consolidation phase. This phase entails a long period of immobilization where the stretched callus is allowed to mature with the support of the device, keeping the callus in a stretched and stable position as well as preventing cartilaginous intermediate. Remodeling starts by allowing the formation of lamella bone with bone marrow elements over a period of time. The duration of the consolidation phase is around 4 to 12 weeks, with 8 weeks being the average. Clinically, it is suggested that the consolidation phase is kept as twice as long as the activation phase, and the timing of the consolidation periods depends on the location of the distension site and the rate of bone metabolism. Next come the distractor devices. This is the classification of distractor device. We can divide into the external devices or internal distraction devices. External distraction device is bone consisting of fixation clamps and distraction rods which are attached to the bone by percutaneous pins. Internal devices can be placed subcutaneously or intraorally and subdivided into bone, tooth bone, or hybrid. It is a combination of bone and tooth bone. The devices are available in different vectors of distraction. Most commonly used is unidirectional or single vector devices distractors. There are also bidirectional, multidirectional, and curvilinear distractors also. External device allows better vector control in multidirectional landing with adjustment possible during the distraction period. Internal devices carry less morbidity, but both types of distractor device are associated with their own complications. Now we come to the clinical application of the distension osteogenesis. The first is alveolar distension osteogenesis. In deficient alveolar bone height for implant placement, distension osteogenesis could increase bone level up to 16 mm at the rate of 1 mm per day. However, comprehensive assessment is required in a severely resorbed ridge as minimal thickness for both basal and transport segments are necessary for the fixation of the distractor plates. It is also very important to ensure the lingual or palatal mucosa remains intact to the transport segment for vascularization. Mandibular distension osteogenesis in microgynecia or mandibular hyperplasia. In anterior-posterior direction, distension osteogenesis can be considered when superior mandibular body segment is needed, body landing is needed. In comparison, a conventional bilateral sagittal split osteotomy may allow up to 10 mm of jaw landing, while up to 30 mm advancement could be achieved with distension osteogenesis, subjected to the size of the device. Mandibular distension osteogenesis is often indicated in cases of obstetric sleep apnea, secondary to conditions such as trichocolin syndrome and non-syndromic microgynecia. Improvement in apnea-hypnea index AHI score could be seen after 15 mm of distension osteogenesis, and the distension could continue up to 25 mm until an acceptable AHI index of less than 5 mm is achieved. Next is maxillary distension osteogenesis. Maxillary advancements in patients with obstetric sleep apnea, secondary to severe maxillary or mid-face hypoplasia, cleft maxillary hypoplasia may also need superior segmental advancement to correct the class 3 jaw discrepancies. Traditional Leaford 1 osteotomy with superior advancement may carry the risk of significant relapse due to scar formation and soft tissue memory. Distension osteogenesis allows controlled soft tissue expansion and consolidation period, thus reducing this problem. Leaford 1 osteotomies and distension are used in patients whose deficiency involves the lower maxilla. Leaford 2 and Leaford 3 osteotomies and distension osteogenesis are utilized in the patients with more extensive deformity in the mid-face region. Transport distension osteogenesis. It can be indicated in a patient condition where significant defect is present. Defect can be secondary to post-ablative procedures such as in maxillectomy, huge cyst in enucleation, or congenital conditions such as in facial clefts. The challenging aspect of transport distension osteogenesis is to ensure the vascularity and maintaining an intact distension chamber, as failure to do so may lead to transport segment resorption, resulting into a more severe defect. Next comes the craniofacial distension osteogenesis. The complex congenital craniofacial cases such as syndromic craniosynostosis may cause serious functional impairments. These conditions include Crogen syndrome, Apert syndrome, by face syndrome, in which patients may suffer serious functional problems associated to increased intracranial pressure, severe astigmatism, and obstructive sleep apnea, secondary to structural growth abnormality related to the early fusion of cranial sutures. Distal osteogenesis of the forehead, front of the skull, and mid-face are needed to correct the deformity. This is called frontofacial or monoblock destruction. Destruction osteogenesis may also be a treatment option in cleft patient with severe defect on the alveolus or tooth-bearing area of the maxilla also. Patients with these problems often require massive segmental expansion of the skull and mid-face region to decompress the restricted intracranial space, achieving orbital protection and eyelid closure, as well as opening up the nasopharyngeal space to treat the respective functional issues. Devices used for these cases may either be an external distractor device or internal devices, or a combination of both. Distal osteogenesis of the forehead, front of the skull, and mid-face are needed to correct the deformity. This is called frontofacial or monoblock destruction. And distal osteogenesis has been utilized in the management of certain patients with craniosynostosis. This is called cranial vault distal osteogenesis. Craniofacial distal osteogenesis in face syndrome patients incorporates external and internal devices. External device in which the head frame is fixed at the parietal region using percutaneous cranial pins, uses pulling mechanism by wires at supraorbital and maxillary regions to advance the bone. Internal device at zygoma areas uses pushing mechanism to push the bone forward. The combination of these two mechanisms provide a stable destruction of the mid-face bone with equal distribution of the forces. Despite its huge size, this external device is made of lightweight aluminum, titanium, and carbon fiber components for patient comfort. This is the advancement of the distal osteogenesis, automated continuous distal osteogenesis. Currently available distal devices are patient and surgeon dependent. The patient must adjust the manual control 2 or more times daily, often over long periods. Because non-compliance and device failure are the leading causes of the treatment failure, the patient requires numerous clinical visits to ensure proper distractor activation. Considering these drawbacks, many research groups are working to design novel distraction devices that expand automatically and continuously. An automated mechanism would eliminate the need for patient compliance and decrease the frequency of post-operative visits for patient supervision. At the moment, the types of the devices are classified into 3 categories based on the method of power: hydraulic, motor driven, and spring mediated. There are some complications associated with the distal osteogenesis, like relapse. Some degree of relapse is likely to occur with any distal osteogenesis, especially that of the mandible. However, overaggression of 10 to 30% depending on the anatomic site will often account for the expected degree of relapse and yield a good clinical result. Next, device failure may happen. This is defined as occurring when the device itself breaks and is relatively uncommon. There are different rates published in the literature and they are slightly different according to the location of the destruction. The highest rate of device failure are in mandibular destruction, but even then they are near 1% only. Next is device extrusion. This is a rare complication where the device extrudes through the skin, migrating through the bone rather than moving the bone itself. This is a manifestation of the orthodontic rather than the desired orthopedic forces. The root cause is the impingement of the bony segment or other regions that the bones cannot move freely in the desired vector. It is essential to test the mobility of the segment in relation to the osteotomy under direct intraoperative and visualization to ensure that they are free to move in the desired vector. Easy to tooth bursts. This is principally encountered in mandibular destruction osteogenesis, though it can occur in the maxilla as well. This can be avoided with careful preoperative planning. Based on preoperative planning, careful placement of the osteotomies as far distally as possible, and avoidance can potentially be enhanced via 3D imaging and virtual surgical planning. allowing for optimization of the osteotomy site. Next complication may be the nerve injury. The inferior alveolar nerve, branches of the facial nerve as well as the supraorbital and infraorbital nerve are at risk of injury depending upon the approach used and the bone to be distracted. Care with the plane of distraction as well as the location of the osteotomy will help to avoid nerve injury. The technique described above will minimize the risk of inferior alveolar nerve injury during mandibular distraction. Permanent or severe injury to the facial nerve are very rare, accounting for less than 1% of complication for all craniofacial distraction procedures. Scarring is the next complication may happen. The use of an irregular or irregular incision can minimize scar prominence. Incision should be closed in layers and electrocoating should be minimized at the scalp surface to avoid the death of the hair follicles. Similarly, rainy clips should be avoided to avoid pressure necrosis of the follicles at the incision edges. There may be some degree of tension present after the cranial vault is reconstructed, which can precipitate hypertrophic scarring. Next comes the infection. This is minimized by the use of systemic antibiotic perioperatively and topical antibiotics to the incision postoperatively in the high risk operations such as LIFO 2, LIFO 3 or monoblock advancement. Prophylactic postoperative antibiotic is indicated as the untreated meningitis rate approaches 10%. Ceftriaxone is commonly employed, as are other antibiotics that cover skin and hair flora but have good CSF penetration profiles. Malocclusions. Manipulation of the dentition bearing bones inherently carry the risk of malocclusions. Even with the use of dental splint, the rate of symptomatic malocclusion is very high in patients undergoing maxillary advancement. Similarly, the future need for orthodontic is very high in patients who have undergone neonatal mandibular distraction. If the patient needs to undergo either of these procedures, regardless of the age, should be counseled. They will very likely CSF next complication may happen the CSF leak. This is rare, but now it can occur with either anterior or posterior cranial vault expansion. So it should be avoided. Thank you very much for patience listening. Thank you.